progression-free survival than treatment with chemotherapy alone. Now, there was no overall survival benefit seen with that, primarily because of length of follow-up, but also because there are successful relapse strategies for the treatment of Hodgkin lymphoma. And those 3 trials have been meta-analysed, and with more than 2,000 patients, we see that omitting radiotherapy doubles the risk of relapse. Again, there was no overall survival advantage seen in that meta-analysis, but as I say, maybe that's a limitation of time and numbers. And interestingly, harking back to the breast cancer story, for many, many years, people thought that radiotherapy for breast cancer simply reduced relapse and didn't affect breast cancer mortality. And it was only after 20 years of follow-up and the meta-analysis of many trials and tens of thousands of patients that survival benefit of radiotherapy in breast cancer could be seen. So you need the time and you need the numbers. And interestingly, in large observational studies, such as the one cited here, radiotherapy is a significant predictor of survival, overall survival in Hodgkin lymphoma. But there remain concerns over the late effects of radiotherapy, particularly cardiovascular disease and second cancers. And this really was the driver behind these trials trying to omit radiotherapy, is to see if you can get the cure rates that were as good whilst avoiding these late effects of radiotherapy. So switching to those late effects of radiotherapy and different sorts of data. So this is data from detailed clinical cohorts based in the Netherlands. They're large cohorts of Hodgkin lymphoma survivors. And we've done a series of studies in collaboration with them, so case control studies, looking at cardiac disease in Hodgkin lymphoma survivors. So essentially what we do in these studies is retrospectively assess what the dose to the heart and the cardiac substructures would have been amongst cases and amongst controls, and then compare them with some magical statistics, which I wouldn't even try to explain, particularly in a short time, to give a dose-response relationship. So we can see here a dose-response relationship between doses to the heart valves and the relative risk of valvular heart disease to the heart and the risk of coronary artery disease. And then this was a study that George did as part of his DPhil, a relationship between dose to the left ventricle and risk of heart failure. So we have these relative risks of heart disease by dose to the various structures. Then switching back to the trials, so this is data from the RAPID randomized controlled trial, the UK study in early stage Hodgkin lymphoma. We can get some individualized doses for what doses the heart of these patients was actually receiving on an individual basis. And you can see from these figures here that, for example, in those having mediastinal radiotherapy, there's just a normal distribution of dose, with the majority of the patients getting a moderate heart dose and only very few getting very high heart doses. And similarly, dose to the neck is sort of a bimodal distribution, which reflects whether people are having unilateral or bilateral neck irradiation. And these individualized doses allow individualized prediction of the relative risks for cardiovascular disease. So that gives us the relative risk. But as I say, we need to calibrate that in terms of absolute risks. And in this example, we did that by using incidence rates from UK population-based data, this Caliber research platform. And we had age and sex-specific rates of incidence and death from cardiovascular diseases from this source in almost 2 million people, with which to make predictions on the absolute excess risk with radiotherapy. So this is how it works. We have the case control studies in cohorts that give us the relative risk by dose. We have the trial data that gives us the individual doses, and then we have the population data that give us the absolute age and sex match risks, and we put them all together to give an absolute excess risk from radiotherapy in terms of these cardiovascular diseases. And we did this for the RAPID trial, and this is what we saw. So for the majority of patients, the risk was very, very small. So you can see this is the individual radiation-related excess risk, and the majority of the patients are sort of down here, but the range is very wide. Although the average 30-year mortality was only about 0.5%, the range of that went from virtually nothing up to about 7%. You know, it was less than 0.5% for 2/3, but there were this substantial minority had a mortality risk of more than 1%. And similarly, for incidence, a wide range, with some getting very low risks and a few getting very high risks. So, you know, these risks vary substantially, and they clearly need to be balanced against the known progression-free survival advantage of radiotherapy on an individualized basis. There's no point taking the average of 0.5% and saying that's the answer, because the range is so wide. You really need to individualize these assessments to help you make decisions. So that's individualizing the risks. What can we do about individualizing the benefits of radiotherapy in Hodgkin lymphoma? So this was another study that was published last year, again from the RAPID trial, and they analysed the effect of maximum tumour diameter, so the largest lymph nodes available from the baseline CTs, and related that to the risk of relapse. And they analysed it in terms of cutoffs and found that a cutoff of 5 centimetre has the highest discriminative value in terms of it gave the highest hazard ratio and the smallest p-value. And the conclusion that they came to was that patients with a baseline tumour size of equal than or greater than 5 centimetres have worse outcome and are likely to benefit from radiotherapy. And that cutoff has actually gone on to be used in the design of the RADAR trial, which is the follow-up trial, which will be opening soon. But that result really has more to do with the distribution of tumour size in the cohort than any special significance of 5 centimetres. And what they actually saw and reported was a linear association between maximum tumour diameter and event-free survival. It has a ratio of 1.19. So approximately a 19% increase in the risk of Hodgkin lymphoma relapse per centimetre increase in tumour diameter. So rather than just using a cutoff, what happens if you model that relationship? It's not a dose-response relationship, but it's a size-relapse relationship. And this is what you see. So with the different maximum tumour dimensions down the side here, you would model that the expected reduction in relapse with radiotherapy would vary from about 4%, go up to about 10%. So you get that average of 5 or 6% that was seen in the trial. But you can see from the distribution of the tumour sizes is that the vast majority of patients in the trial had a smaller tumour size. And 82% of the patients had a tumour size of less than this 5 centimetre cutoff. So if you do use that cutoff, you'll only be preventing 25% of the relapses that could be prevented with radiotherapy. Whereas if you used a lower cutoff, for example, 2 centimetres, you'd be able to prevent 80% of the relapses. And yes, you get a slight detriment in the number needed to treat from 13.1 up to 16.7, but you know, you'll be harnessing a lot more of the potential benefit of radiotherapy by choosing a lower cutoff. And well, this is a danger of a cutoff in my eyes. I don't like cutoffs. Radiation oncologists use them a lot, but a lot of the time a cutoff is a relatively arbitrary line drawn on a relationship, and I think you get a lot more information by looking at how the the numbers play out over the whole scope of the problem, rather than just focusing on a single cutoff. So this would be the ideal. I mean, it's clear from those three trials that a complete metabolic response on PET-CT is not enough to identify the patients who do not benefit from radiotherapy. That isn't the answer. And really the decision needs to be based on an individualized estimate of the benefits, perhaps through maximal tumour dimension or perhaps through other indices such as metabolic tumour volume, and an individualized assessment of the risk dose, age, sex, and other factors for cardiovascular disease, and also second cancer risks, which we haven't looked at in this study, but we have looked at in other contexts. But it seems that the risks vary substantially more than the benefits are likely to be the key to decision making. So that's an example about deciding whether to use radiotherapy or not, or two examples about using radiotherapy or not. But really withholding radiotherapy completely is the most extreme option when it comes to avoiding risks of radiotherapy. But exactly the same techniques that I've described can be used to compare different radiotherapy modalities or radiotherapy techniques. And indeed, George has just recently published this paper looking at proton beam therapy for supradiaphragmatic lymphoma that does just this. And this was a collaboration between Oxford and George guys and some colleagues from the Prague Proton Beam Center. So again, we've got this method of combining the data. So we've got proton beam therapy doses from the Prague cohort, which George replanned using optimal photon techniques, such as user guys, and combined the proton doses and the photon doses with the relative risks from our case control studies, so cardiovascular disease and second cancers in this example, and then got absolute rates, so population-based mortality rates, and combine them to get the absolute risks from proton beam therapy, the absolute risks from photon radiotherapy, so we can ask what's the difference, and then also ask how does that difference vary with different groups. And I hate to sort of rush through these results and not do them adequate credit, George, I apologise, but effectively, you know, the benefits from proton beam therapy were small overall. What we can see in these charts on the left here, separate charts for cardiovascular disease, lung cancer, breast cancer, and esophageal cancer, is grey, the background risk in these populations, which varies from country to country. For cardiovascular disease, the risk from chemotherapy, and then in yellow, the photon risk, and in blue, the proton risk. So to look at cardiovascular disease in the USA, you're getting a 0.1% reduction in cardiovascular disease mortality with protons. Lung cancer, slightly larger, 0.4% reduction in the risk in lung cancer mortality with protons. But it's important to note that the risks of cardiovascular disease varies much more by country than it does by radiotherapy technique. And also interesting to note that the cardiac risk from anthracyclines is similar to or greater than the risk from radiation. In terms of which groups benefited most, so although on average the benefits from protons was relatively small, for the 30% of patients where the mediastinal disease overlapped the heart by more than 40%, which we can see in the dotted lines on the left here, protons reduced the risk, 30-year risk of cardiovascular mortality by 0.8%. So a more substantial benefit from protons here versus the solid lines, the others where there was virtually no benefit from protons. And also comparing the males versus females, the absolute benefit in men was higher than it was in women because the background risk is higher in men than in women. And similarly, when the axilla was irradiated, the lung cancer mortality benefit was higher because the lung dose was higher, or the difference in lung dose was higher. Smoking, importantly, had a much more substantial effect on the risk of lung cancer than the radiation dose did. And because of that, the benefits or reduction in risk with proton therapy in smokers was higher. Does that mean we should only refer patients who smoke? I doubt it. But you know, it's an interesting facet to this research. One other important thing to mention is this is mortality. Proton beam therapy will undoubtedly have a greater absolute impact on the incidence of these events, particularly breast cancer, where the mortality is relatively low. But you can see how this work can help define the subgroups that we should perhaps be preferring for proton beam therapy referral. We're also collaborating with some health economists within our department, who are pictured here. And this is another way of looking at it, really. Rather than just incidence and or mortality, you can look at the benefits or detriments of radiotherapy in terms of quality adjusted life years or actual financial treatment costs. And an analysis of chemotherapy alone versus combined modality therapy for early stage Hodgkin lymphoma has just been accepted by Blood Advances. And we're also currently working on an analysis of proton beam therapy versus photon radiotherapy for mediastinal lymphoma, and looking at it from a health economic perspective. So just a quick example of the results from this recently accepted study. So these top series of panels is life years, and then there's quality adjusted life years, and then there's quality adjusted life years with a 3.5% discount for future health. And that's a concept that's used in health economics, and it's about the fact that individuals and financial institutions value things that happen in the future a little bit less than things that are going to happen in the next year. And the bars show the mean difference in terms of life years or quality adjusted life years between combined modality therapy or chemotherapy alone. And if the bar is above the 0, that's favouring radiotherapy. And if it's below, that's favouring no radiotherapy. So you can, and the 5 columns are the smallest radiotherapy field on the left. So that's just a unilateral neck treatment, right the way through to sort of old-fashioned mantle field type radiotherapy on the right, the largest radiotherapy field that we'd ever consider using for Hodgkin lymphoma. So you can see that larger fields favour chemotherapy alone when you're looking at life years, but this difference is reduced or even reversed by quality adjusting the life years and with the future health discounting. So it's interesting that both of these concepts, the quality adjustment of life years and also the future discounting, could reverse the direction of your decision about whether radiotherapy or not was a good idea. So we're doing much other work as well. There's an anthracycline meta-analysis ongoing, which I'll give a hint at on the next slide. There are many breast cancer projects led by Carolyn Taylor. We're doing a case control study of colorectal cancer in Hodgkin lymphoma survivors, which is being led by Rebecca Shakir, who's a clinical oncologist, PhD student with us at the moment. And she's also doing an interesting qualitative study of shared decision-making in Hodgkin lymphoma at the moment. Another study that Rebecca is involved with Victoria, who I saw on the call, I think, and George, is a method to try and predict organ doses from pre-chemotherapy PET-CT scans in lymphoma. So the aim of that would be to try and predict the radiation doses to organs at risk and the risks themselves right at the start of the treatment pathway, to try and start making those decisions early on in the pathway rather than waiting until we've got a radiation plan to be looking at. We're also commencing a case control study of stroke in Hodgkin lymphoma survivors, continuing our collaboration with the Netherlands team. And in a similar way to the PHE data we have on breast cancer, we also have access now to the PHE lymphoma data set. So that's more than 200,000 patients diagnosed over the last 20 years or so, which we're going to use to calibrate our lymphoma work going forwards. So as I say, this is the anthracycline meta-analysis. As I say, this is work in progress, so confidential, not for wide circulation, please, but this is data from more than 60,000 patients in 85 trials. So that's breast cancer trials, but also lymphoma trials and many other cancer types. And this is major, so severe or fatal cardiac events by dose. And you can see a clear increase of relative risk with dose. So each cycle, if you like, of anthracycline is increasing the risk by a factor of 1.14, and that's a factor. It's a multiplicative effect. It's a non-linear effect. And provisional calculations trying to convert this risk ratio into absolute effects suggests that some of the standard breast cancer regimens that are being used at the moment might increase the risk of severe heart disease by more than 5% in some women. So they could well be outweighing what we'd anticipate as a benefit from chemotherapy. And this is just another example of an important thing that should be included in calculators such as NHS Predict in the future to help us make the best decisions for our patients. In terms of things to think about, unanswered questions, still very much up in the air what the best dose volume metric for radiation risk prediction is for a variety of different endpoints. Retrospective dosimetry, reconstructing doses from treatments delivered 20, 30 years ago is limited. And as such, many of the current models use mean organ dose only. Because of the latency of late effects, we're limited as to how much we can use modern CT-based dosimetry to make these dose-response relationships. But we're starting to realise that doses to specific structures might give us better relationships. Doses to coronary arteries rather than the whole heart, for example, might give more accurate relationships, and these dose-response models will undoubtedly evolve with time. We're also learning more about genetic sensitivity. These late effects, we're starting to see some SNPs for sensitivity to anthracyclines as an example, and genetic sensitivity for radiation-related side effects is a very active area of research. It'd be interesting to wonder, will these genetic tests become part of decision-making in the longer term? But with all this extra information, making these decisions is increasingly complex. What is the best way to do this? Is the way forward to make decision tools such as NHS Predict ever more complicated, including more and more data? And how much should we involve the patients in these decisions? What process of shared decision making should go into deciding what's best for an individual patient? So that's just some thoughts to put out there really for the future. And I probably talked for far too long, which I apologise. But thank you very much for your attention.
That was really interesting, David, and really very productive work. I don't know why this. Is there any question? I have one question, David. I just start with. When you look at the prediction model, obviously you talk about using the randomized controlled trial data, some real world data. Do you try to give weighting for sort of more weight to the randomized controlled trial data, or you just integrate all the data available?
We tend to use the best source of data that's available for the purpose, if you like. So it's more about what do we think is the most reliable source of a particular risk or rate, and use that rather than weighting it in any particular way. And there's no doubt that the proportional effects of treatments are far the best if you can get them from randomized controlled trials, because that immediately removes all the bias. But when you're trying to apply that to a real world patient, you've got to use real world absolute risks. And there's no point using absolute relapse risks from 30 years ago. They're just not going to be reflective of what's going on in modern practice. So you've got to sort of, as I say, it's a sort of calibration process, if you like, to update the absolute benefits of treatments. So yeah, it's not that we have a statistical method for weighting the quality of the source of the data. It's just that we have a principle of using the best tool for the job, as it were.
But I suppose selection of the sources will be important then, as you said. Yeah. And normally when you do systemic review, you have a systematic way of selecting certain data to include. But in your title model, do you do that, or you just know which is the best? How do you know which is the best data to use, other than all those well-known randomized trials?
quite often there isn't much choice, to be honest, and quite often it's data that we've produced ourselves, so we're bound to think it's the best. But yeah, there often aren't that many competing sources of, or haven't been that many competing sources of data. That's starting to be more and more of an issue. I mean, particularly radiation-related heart disease is quite a hot topic at the moment, and there are lots of studies that have been published over the past few years looking at that risk in lung cancer, for example. And you know, the answers that you get from breast cancer, from Hodgkin lymphoma, from lung cancer, they all point in the same direction, but quantitatively they can be quite different, and they can use different dose volume metrics or organs at risks and so on. So as more and more people get involved in this work, I think that's going to become more of an issue, you know, choosing which data to use, which study to believe more than another.
Okay, George, you have a question?
Thank you, Anthony. Thanks, David. It's an excellent talk. My question really is related to the prediction. Most of the studies that gave us those response relationships were driven from two-dimensional or parallel pair radiotherapy, including mantle and so on, where the OAR received more or less homogeneous dose, and you're looking at those levels across the organ. Nowadays, with IMRT, the specific OAR will have received a range of doses across the volume. And how do you translate between old radiotherapy and new IMRT exposure of OARs?
Yeah, you can't to a great extent, and that whole, you know, what matters more, a lot to a little or a little to a lot question is a very active one. I think for cancer prediction, it's less of a concern in my mind. You know, there's a wealth of evidence suggesting that the relationship between radiation dose and second cancers is linear with no threshold. So on that assumption, you know, mean organ dose is the be all and end all. The distribution shouldn't make a difference for cancer prediction, at least. And the initial worries about IMRT increasing the risk of second cancers, for example, seem to be fairly unfounded. There isn't a great deal of evidence for that. So I think, you know, second cancer predictions, it probably has less of a bearing. I think it's probably got more relevance when you come to predict heart disease risks, you know, maximum dose to a coronary artery and so on. We're beginning to see that that's potentially important, and factoring in that dose in homogeneity, particularly for cardiovascular risks, is going to become increasingly important going forward. But sort of answer the question about retrospective dosimetry, I think George is probably best placed to answer that, actually. Because, we did a study comparing a few different retrospective dosimetric methods against CT-based predictions, and you know, the predictions made by the different methods didn't alter the risk dose response relationships by very much at all. So we can be reassured to an extent that our results are valid, but it's going to become more complicated going forward.
Yeah. I guess my concern is related to the fact that we are now using a different modality with different exposure of OARs, and it might be that different organs will have different models of dose response relationships. So you just alluded to the difference between cancer and heart. And I guess also organs like a left ventricle might have quite a different dose response relationship to a coronary, where a small stenosis in one point will be quite significant. So whether you look at the mean dose or the maximum dose, it might be very different depending on the organ we're looking at. And this is in a way, a fertile area of research, but it's just a new uncertainty that we need to think about with IMRT.
Yeah, no, I agree completely.
Okay, thank you both. because of the time, so we'll proceed to the next speaker. It's our own Kazumi Chia, who is our consultant oncologist at Guy's. Kazumi has been here for a long time, from medical school and then registrar training, and she did a PhD also in the imaging department. So we're very looking forward to her talk. She's going to talk about her previous work. Thank you, Kazumi.
Thank you, Anthony, and thank you for inviting me to share my work today. So I'm just going to try and share the screen. Can you tell me if you can see my slide? Because I'm having,
yes, we can see.
Yeah. Okay, brilliant. So I'll just play that. Is it okay? I haven't done any animations because I think that's always a problem on Teams. Okay, so so I was appointed just in February of this year into the Neuro-oncology unit here at Guy's and St Thomas's. So I'm sort of on the other end of the experience spectrum to David. So I'm a new consultant, but also I'm new at this trust. But as Anthony mentioned, I did part of my training here at GSTT, but also my PhD was in the Imaging Sciences Department at KCL. So I've made the title of today's talk, Direct Correlation of Hypoxia PET Tracer Uptake with Hypoxic Radioresistance. So my work was mainly a preclinical project looking at hypoxia PET tracers and trying to draw some direct correlations with cellular radioresistance. So I'm sure I don't need to really speak too much about tumor hypoxia. It's a very established clinical and also preclinical problem, and since its discovery more than 50 years ago, we know that it's actually a very common feature of many solid tumors. And not just in terms of radiotherapy resistance, but we know that tumor hypoxia influences cancer prognosis, but also response to other treatment modalities in oncology, such as chemotherapy and surgery. And hypoxia has been mainly categorized into two types, so the diffusion-limited chronic hypoxia and also the acute hypoxia that occurs when sort of abnormal vessels are transiently occluded. So non-invasive imaging using PET imaging, for example, has been established for quite a while in research. And so here we have an example of a patient who has a head and neck cancer, a piriform fossa cancer. And if we just look at this, I don't know if you can you see my cursor? Yeah. The black arrow is pointing to the primary, and then the red arrow here is pointing to the neck nodal mass. So you can see with the FDG PET, which is a very common imaging modality to stage head and neck cancers, that both the primary and the neck nodes are lighting up on FDG PET. But if we look at the F-meso hypoxia scan, there's uptake in the neck node, but the primary lesion is not taking up the hypoxia tracer. So now if we look at the bottom row, we can see the same patient, but 12 weeks following radical chemoradiotherapy. And this is an FDG PET scan showing that there is evidence of residual disease in the neck node, but not in the primary site. And the patient underwent neck dissection, and this was confirmed histologically. And then another example using copper ATSM. So in this case, they use copper 60 in cervical cancer. So if we look at the top row here, we've got the primary tumor marked P, and then the bladder marked B. So there is uptake in the primary site of copper ATSM, but the FDG scan shows uptake in the bladder and a different sort of a heterogeneous uptake in the primary lesion. And in a different patient, considered non-hypoxic, the cervical primary didn't show uptake of copper ATSM, but the FDG scan showed uptake, and obviously the bladder uptake, as you would expect with FDG. So how do we define hypoxia when we're talking about trying to target with, for example, PET imaging? So quite often you hear people talking about hypoxic tumors and normoxic tumors, but really we know that the oxygen gradient is actually a continuum from, let's say, the atmospheric levels down to the cell level. And this is just a sort of a diagram sort of representing that. So when, for example, experiments are performed at normoxia and using oxygen levels that are found in the atmosphere up here, really that's not a very physiological normoxia. It's more of a hyperoxia when we're trying to mimic an in vitro or in vivo situation. So that's I think the other thing to think about. And so we do need to be thinking about what kind of hypoxia or what degree of hypoxia we're targeting when we're trying to image. So this is one of the main reasons, I think, that makes hypoxia targeting or hypoxia imaging incredibly complicated, because in other molecular targets for PET imaging, we have a clearer target that's easier to define. So here on this list, you'll see a number of familiar targets: alpha V beta 3 integrin, PSMA, hexakinase for FDG, and thymidine kinase looking at cell proliferation with FLT PET. So in these sorts of situations, it's easier to talk about what we're actually trying to target and be more certain that we have identified this with our imaging agents. So, okay, if we're trying to target hypoxia, then what level of oxygen are we trying to image with PET? So in the literature, in terms of misonidazole and other hypoxia tracers, there are sort of varying thresholds where it is said that the uptake starts to increase. So it may be 10 millimeters of mercury, 3 or 1, it varies. So how are these thresholds being measured when these tracers are being assessed? And the thing is, it is incredibly difficult. So quite often, studies will be quoting the oxygen concentration in the gas cylinder that's being used to gas the cells. But when you have a cell population or a cell suspension where you have live cells that are metabolizing, they're constantly using up oxygen. And you've got the issue of diffusion of the gas phase oxygen through the cell culture medium to get to the cells, because we're interested in the oxygen that the cells are in contact with. So this is a very sounds very straightforward, but actually when you try to do it, it does become very complicated. And this is hopefully hopefully it's a clear way of just explaining this. So in my in vitro studies, I just got here on the y-axis here the ratio of the expected oxygen concentration according to what gas cylinder I had connected up to my setup, and then the observed oxygen concentration with my oxygen probe in the cell culture medium. So when I just had the cell culture medium, the expected so this is the expected oxygen concentration, but as soon as you add the cell culture medium, actually that remains pretty similar to the expected. But when you add the live cells, you find that the oxygen concentration is significantly different to the gas concentration that's going into your cell medium. And that's particularly marked when you're dealing with the low oxygen concentration, so less than 10 millimeters of mercury. And you can imagine the less oxygen that's available, and if your cells are you're just working through that oxygen, then the harder it is actually to be certain of what your measured oxygen concentration is, and the size of the error can be significant. So in terms of what kind of hypoxia we want to target, then we want to target cellular radiosensitivity, the oxygen level that impacts on cellular radiosensitivity. And we know from very old studies that cellular radiosensitivity starts to reduce at around 20 or 25 millimeters of mercury. So the aims of my project was to first determine the extent to which cellular radiosensitivity and markers like HIF1 alpha expression correlated with the PET tracer uptake. And this was all done within the same in vitro system. So I was using the same method of measuring the oxygen concentrations under identical controlled conditions. And HIF1 alpha was chosen because, in a way, it's the way the cell senses hypoxia. It's the key transcription factor for hypoxia. And And secondly, this was done with a continuous measurement of the oxygen concentration rather than using the gas cylinder oxygen concentration. And the intention was to then apply these results to better understand how to apply these PET tracers and how to interpret imaging such as the F-MISO and copper-ATSM imaging that I showed you earlier on. So I'll just quickly go through the steps. So initially, I actually had to custom build hypoxia apparatus in order to perform these experiments. The experiments had to be, there were multiple experiments, and so I needed to be able to irradiate these cells in this setup using the cobalt teletherapy unit that was at St. Thomas's, also then perform cell survival, clinogenic assay with these cells, and also the HIF-1 alpha expression assessment using Western blotting and tracer uptake using gamma counter, and also pymanidazole binding using flow cytometry. So the setup had to enable all these experiments to be done under these identical conditions. So this is the kind of setup that I spent some time developing, and I won't spend too much on that. And then the same setup is then used to irradiate, and I worked with Mariam in the physics department to just check the dosimetry of all of this. And then I had everything on a trolley, then I have to take it down to the radiotherapy department and set it up. And so people saw me regularly up and down the lifts, down to the basement doing this. So the results, starting with cellular radiosensitivity. So for both of the cell lines I used, it was a colorectal cell line and a breast cancer cell line, the radio resistance sort of kicked in around 20 millimeters of mercury, which is not that different from the data I showed you from the literature. And in terms of the pymanidazole binding, again, the binding increased at around 20 or 25 millimeters of mercury. And the HIF-1 alpha expression steadily increased when oxygen levels dropped below 50 millimeters of mercury, and then maximum levels at anoxia or 0. So with the tracer uptake, which is very different, and I've put this on a log scale because as you can see, sorry, it's a bit of a crowded graph, but these are all of the, there's ATSM on there, there's F-MISO, but also I looked at some of the copper ATSM analogs because there was some data suggesting that these analogs of copper ATSM may have different thresholds of hypoxia uptake and different pharmacokinetics. But putting these all together, you can see that there isn't really significant uptake until you go below 1 millimeter of mercury, and really no uptake above those levels. So quite extreme levels of hypoxia required. So if I just summarize the results of the PET tracer uptake, radiosensitivity, pymanidazole binding, and the HIF-1 alpha expression on the same Y and X axes, you can hopefully appreciate that actually the radiosensitivity and the pymanidazole binding and perhaps the HIF-1 alpha expression have sort of similar levels at which they are turned on, but the PET tracer uptake has quite a different oxygen threshold with, again, very extreme hypoxia required to show uptake. And that was for both of the ATSM and the F-MISO tracer and the analogs. And this is just a quantitative summary with an estimation of the half maximal value relative to anoxia. So again, for the PET tracers, this is a very low level. This is in millimeters of mercury of oxygen, and even lower for F-MISO. And when you look at the relative radiosensitivity, HIF-1 alpha response and pymanidazole binding, the levels are higher. So the conclusion of my work is really to say that it highlighted this important mismatch between the oxygen thresholds between the PET tracers and other markers of hypoxia, and also that the tracers were only retained in the cells when the oxygen levels were well below the levels that induced radioresistance, pymanidazole uptake, and HIF-1 alpha expression. So you might ask, well, what are the relevant oxygen levels that occur in the clinic? You know, are we seeing, is it the most extreme level of hypoxia that the PET tracers are detecting, or are we seeing the clinical relevant oxygen levels are more in keeping with the pymanidazole or the HIF-1 alpha expression thresholds? So, you know, we can look at the Eppendorf electrode data. So these are probes that are inserted into human tumors to measure the PO2, and this is some data pulled together of a number of studies showing the median PO2 of these human tumors. So you can see that there is a range. So these studies correlated these measurements to outcomes for these patients and found that there was a threshold of about between 2.5 to 10 millimeters of mercury, where there was an association with a poorer outcome for these patients. So what about these hypoxia PET tracers, F-MISO, cooperative SEM? Are they able to predict radioresistance? Are we only identifying such extreme hypoxia? So we're missing a lot of clinically relevant hypoxia that we see in human tumors. Well, we do have to remember, you know, we are measuring in different areas depending on the modality that we're using. So I just showed you some data using oxygen electrodes, and really they're measuring the oxygen levels in the tumor interstitial space. PET tracers or SPECT tracers are interested in intracellular oxygen levels. And again, other modalities such as bold MRI or optical imaging are going to be measuring the oxygen concentrations in blood vessels. So I think these are complementary measures of hypoxia, but we just need to understand that you will not expect to have a direct match between these different modalities if they're measuring in different locations. And we will be seeing, if you have highly metabolic tumors, that they're going to be a very steep concentration gradient between these compartments. So these PET hypoxia tracers, can they predict radioresistance? So, well, they seem to be able to target very extreme hypoxia. And so going back to that Eppendorf electrode data, if we look at this, so the clinical threshold of radioresistance that sort of seems to be associated with a poorer outcome with these papers was talking about 2.5 to 10 millimeters of mercury. So in this sort of range, the F-MISO incorporated SM appears to be only taken up at these very extreme levels of hypoxia. But remember, radiobiological hypoxia, which was measured or calculated using single doses of very high radiation, so 20 gray, 30 gray single fractions, and that identified a population of cells with the most extreme hypoxia were then the limiting factor for response to those high doses of radiation, which I think is analogous to the doses of radiation that we use in stereotactic radiation therapy. And perhaps these PET tracers, if they're really only identifying the most extreme levels of hypoxia, rather than using them in conventional radiotherapy treatment regimes, we should look at, focusing our attention on stereotactic radiotherapy sort of treatments. So that's just a suggestion. And so part of future directions are where I think this data could lead on to is really to look at cooperative SEM or F-MISO tracers in stereotactic radiotherapy. We know from preclinical studies of stereotactic radiotherapy that there is hypoxia present that limits the efficacy of treatment. And also, when you're giving single fraction treatments, particularly, you're losing the benefit of reoxygenation. So hypoxia is highly likely to be a relevant treatment limiting factor. And as an SRS radiotherapist who treats a wide variety of patients with brain metastases, although many of our patients have very excellent local control after treatment, we know that there are subpopulations of patients, particularly colorectal patients, who just seem to have very poor outcomes of local control, even with the high doses of radiation. So I think there are definitely gains to be made in stereotactic radiotherapy for particularly resistant patient groups. And using radioisotopes with a shorter half-life perhaps will also enable this repeat imaging within patients, because what we want to be able to do is offer these patients an intervention to target their hypoxia. So, for example, with carbogen nicotinamide, to see if there is hypoxia present, is it reversible? Can we do something about it? And using a half-life that is shorter than copper-64 enables us to, in practice, perform these studies on our patients. Other sort of interests, sort of future dreams that I have, particularly as a clinical oncologist treating CNS tumors, and I think many people will know that CNS tumors are mainly treated by clinical oncologists in the UK. Because of the difficulty in biopsying brain tumors, we really need to develop non-invasive imaging probes to help us develop new drugs to improve the outcomes to primary brain tumors. So early phase drug development is really being inhibited by the fact that they can't do baseline tissue assessment or post-intervention tissue assessment. So that's a real opportunity for non-invasive imaging to come in and provide a biomarker for that drug development. So it just leaves me to acknowledge the team in the imaging chemistry and biology department, and there are others who are not, having included everybody, but the whole department helped me get through my PhD, and also Mariam Naeem already mentioned her help from the Department of Physics, and also the physics workshop helped me greatly to build the setup that I use to irradiate the cells on the Cobalt machine, and also my funders, Cancer Research UK and the BRC. Thank you.
Thank you, Kazumi. That's really interesting talk. First of all, is there any question from anybody? I will ask first, Kazumi. All the measurement that you've been doing is always pre-treatment. Have you looked at pre and post treatment? Would it make a difference when you measure the using hypoxia marker tracer?
Sorry, what do you mean what treatment do you mean?
The data that you showed to us, are they all sort of looking at the tracer uptake? Are they all from sort of data pre-radiotherapy measurement?
Yeah. So they're basically, so because to do a clonogenic assay, you need to keep the cells sterile. So you can't use, it's the same identical cells were not used to do the tracer uptake. So, it's more the fact that the exact same conditions and the same cells and the same protocols were used, but the cells used, for example, to do the pyrimidinol staining or the irradiation were not the exact same cells that were used to do the tracer uptake. So these are all baseline non-intervention measurements of hypoxia tracer uptake or the HIF1 alpha expression. And
sorry for my ignorance, but from the FI-MISO PET tracer, what is the role you think in terms of clinical application?
I mean, yeah, I think the fluoromyzonidazole is the more established hypoxia tracer. Oh, we've got a question from Rick. Hi. But in terms of the kinetics of the tracer, it's very slow, and I think we have to think about the practicality of using such a slow tracer, but also if you want to be able to do repeat measurements in the same patient to see if your intervention, your carbogen, for example, has been effective, you can't really use a very slow tracer, because by the time you've got your signal, that your intervention sort of, over, if you know what I mean.
Okay.
Rick had a question. Hi, Rick.
Hi, Kazumi. Nice to see you and a lovely talk. I've forgotten, I haven't seen this data for a very long time, but in your data where you show a direct comparison of your various bis semicarbazone complexes, and you're doing a titration against oxygen saturation, it looks like for both CTS and ATS, you actually get a larger amount of tracer uptake at a higher oxygen saturation than copper ATSM. I was quite pleased to see that, because we see that in our hearts too. But I was wondering, because then as you went on, you said that you're going to revert back to copper ATSM in your sort of future ambitions. Would you want to include some of these other traces as a comparison in there, on the basis that they might actually be more sensitive to sort of the radio resistance that you're actually interested in?
Yeah. No, that's a really good question. And I think, coming from some of the PET center discussions about, which PET tracers will try and get into the clinic in the coming year or two, maybe I was sort of slightly pessimistic about, the idea of new trace, because obviously F-MISO and copper ASM have already been in, research studies, and there are examples of where, patients have been scanned using these agents. But I think you're absolutely right. I think, that there are clearly, they're hypoxia specific, and I think if they show a better, for example, tumor to background ratio and things, we should push to be using those. We want the best hypoxia tracer at the end of the day, for these patients, and so yeah, no, absolutely. But I think it's just, I think the reality of trying to MHRA, facing the MHRA, but also the realities of dealing with the PET center in terms of getting these traced out. At the moment, the last time I was in discussion, I was trying to convince them that we should choose copper ASM over F-MISO. So it's difficult, the reality of getting these tracers into clinic. But I think we should keep aiming for which the tracer that is actually the best for the application.
Maybe we should have a pincer attack from both oncology and cardio.
We should. Yes, we should.
So, Kazumi, where is next for you? What do you think you will do next with the?
Yeah. Thank you, and I'm really grateful that we've started these meetings, and from my perspective, the big thing was as somebody who's in a job without formal research time, but having done a PhD and particularly having done a PhD at KCL, I really wanted to have a formal opportunity to be able to keep encouraging the sort of academic side of things, because obviously we all know that the clinical responsibilities can sometimes just sort of squeeze out any academic interest or energy to do academic things. But also, it's so great that Rick is on the meeting today as well, because we have, particularly from an imaging point of view, we have such a fantastic imaging department in KCL in terms of resources and colleagues, and there's been such a huge expansion over the last 10 years. I'm really keen to see that benefit our patients, and it's really inspiring seeing David's talk, because I think that's what we want to do as clinical oncologists, isn't it? To be able to improve outcomes for our patients, be it reducing toxicity or actually improving outcomes. And so, I want to be actively involved in translating this work into our patients, and it'd be great if our patients at GSTT were the first, or they were part of the work to make that happen. I think it's really important to get more clinician engagement, both on the medical oncology but clinical oncology side, with our imaging department at KCL, because if we don't do that, then we can't translate these efforts into clinically relevant applications. So that's what I would like to do, and it may be with a hypoxia imaging agent, that if we can get maybe some pilot studies going to look at that, and being a neuro-oncologist and I mean, could be with primary brain tumors, but particularly I'm interested in seeing in SRS, whether there's a role of looking at hypoxia and looking at targeting hypoxia. I think that's where there seems to be an obvious link. But to be honest, I'm very open to any imaging oncology links, because I think it's such an amazing opportunity. And so I know other clinical oncology consultants have done imaging related research, MDs, PhDs, and so hopefully over these coming months, as we do more of these meetings, we'll hear more from them, and encourage each other and come up with more ideas to develop these projects, and apply for funding for grants to get these off the ground.
Well, certainly, I'm very keen to work with you, Kazumi. So I think there's a few things that, even just for our own group, we have a slightly different focus. And I think with Rachel Evans, she's applied to RadNet funding, where she's going to look at, for example, preclinical model, looking at brain mets from hopefully TNBC. And again, imaging is not really sort of like hypoxic tracer, not being really looking at. So something that in the future could be incorporated. And also thinking about looking at brain met organoids and that kind of thing, measurement of the hypoxia between different patients, hopefully in the longer term, different organoids. And again, that kind of thing will probably need your expertise because of what you have done before. So certainly there will be some kind of interest, joint interest in this field in a different angle, I mean. So I think if you're interested, hopefully we'll meet out some other time to discuss further our potential collaboration.
Definitely.
I noticed that obviously the time is nearly up, and just for remaining few minutes, just for the people who are still in the meeting, I just welcome George and I and Marina. I don't think she's here today. We welcome any feedback about the platform, about the meetings. I think originally, as I said in the introduction, that we call it a forum because we want some kind of interaction between speaker and the audience, and also for people to give feedback and advice. It might be that we, in the future, maybe we need to concentrate not to have too many talks so that people can contribute their ideas to the speakers. So I welcome any comments really for anybody regarding this forum, and we hope to do it maybe once every 2 months. Is that true, George?
Yes, I think once every 2 months it's probably about right. And to get also, obviously imaging from KCL is one of the groups we really want to get involved in these. And so please, Rick and everybody else from King's, invite your colleagues that we don't know how to invite. Yeah, that would be very useful. But also to mention the new computing group that we also invited to participate, led by Harris, that they starting developing these AI models and machine learning models that they can absolutely supercharge the research and do it much faster than what we are usually able to do. So hopefully they will be agreeing to be presenting about how clinicians and scientists can use that group and to be able to enable even better research. Yeah, I think that sounds good. And well, it's going to be 3 or 2 presentations, probably. Maybe 2 presentations might even be better. Originally we thought 3, but probably 2 is a good amount to have more discussion.
And maybe a mixture of discipline, as you said, George. Maybe like someone from physics and someone maybe more clinical orientated.
Yes, it was just this time 2 clinicians, but generally we will be trying to have 1 clinician, 1 scientist, imaging scientist, medical physicist, or whoever is available. So if I know you, I will probably pester you to present at some point. If I don't know you or I don't know what work you do, please email Anthony, me, or Marina to get involved. And another last thing we want to add here is this meeting can be also used if you're planning to apply for a grant and you have an interview planned and you want to present your idea either to practice for your grant interview or even earlier stages. Please do contact us, because you can receive feedback for 40, 50 people. That's fantastic, and it can definitely improve your application later, hopefully. So that's another way we can use this forum for, not just for research we're currently doing.
Is there any comment for anybody?
I think it's a really good start today, and it's encouraging. My main comment would be to create enough space in the meeting for discussion. I think one of the strong points would be that you have a really good discussion around issues and ideas being raised to really make it a proper open forum. Because you can create then ideas, you can stimulate people to go and think and initiate research or initiate collaborations and so on. So I know it's difficult to get people to come up with questions and make comments and so on, particularly in a virtual forum. But I think if we allow time, and the moderators will have a big role in trying to encourage that discussion. I would personally give half of the time of, like if a talk is 20 minutes, I'll give 10 minutes discussion. Or if it's 30 minutes, I'll give 15 minutes discussion, and just really encourage and create that culture of discussion, collaboration, interaction, and so on. So I think that would be one of the strongest. This is not primarily educational as much as it's actually, and that's at least my understanding of it. It's not just an educational forum. It's really to promote discussion, interaction, new research, new ideas, and so on.
Very spot on, George. I think you have really said what we wanted to achieve is really to stimulate discussion, interest. I mean, sometimes people actually don't know. I mean, that's what Kazumi actually pointed out before, that people don't know what each other is doing. And actually just seeing what Kazumi is interested actually made me think that there are few things that we can move forward in a longer term to pursue collaboration. And many other people might have the same interests or want to pursue and want to work with Kazumi for different things. So I think this is exactly what this forum is about. I see that there's somebody else raised a hand. So hi,
it's Sahib. I'm one of the cardiology registrars at Royal Brompton and St Thomas's. I work with both the George and the PET-SMART project we're doing in lymphoma patients. First of all, thank you for the first talk. Both talks are absolutely fantastic. I'm really interested about the impact of the radiotherapy on the cardiovascular outcomes. And I just wonder at this point whether people are thinking about doing surveillance screens and follow-up studies, before the cardiotoxicity happens. Any thoughts on that? Any experiences? Just because I've got an interest in echo and MRI, so I just wondered what others had thought about that.
There are certainly recommendations for screening after anthracycline treatment plus or minus radiotherapy in children and young adults, where the focus on late effects is more well established. Some countries do have recommendation for screening after radiotherapy in sort of adult patients, Hodgkin lymphoma patients, and so on. But no, the guidelines for who is at high enough risk to require surveillance and intervention and what that surveillance and intervention should be is not very well defined at all. There's the European Cardiology Society do some cardio-oncology guidelines, and they're just being updated. I was involved in that process along with some colleagues, but the focus there is very much more on systemic treatments, and particularly on newer ones and targeted treatments and so on. So yeah, the radiation-related effects are treated secondarily, let's say.
So on that note, I just want to thank our speakers again for the excellent talk. I think do write to the speakers if you've got any more queries or any questions about their work or want to collaborate with them. We actually want to invite external speaker, hopefully for every meeting as well, because we want to have more collaboration also with other organizations. If you got any feedback about the forum, please do write to myself or George or Marina. We'll try to sort of listen to you, and I mean, hopefully the meeting sort of will be attended by more people, and people will actually find that it's helpful for everybody. So on that note, thank you so much for your time and for attending on a Friday late afternoon. We appreciate that. People are obviously busy with their own work, but thank you so much for attending. So have a nice weekend, everybody.
Thank you for the invitation. Goodbye.
Thank you. David, thank you, Kazumi. Thank you all.
Okay,
Bye.
bye. Bye.